Hey everybody, welcome back. Today we're going to go through pretty quickly mania and depressive disorders. So, what is mania? Mania is the mnemonic dig fast. So, there is going to be distractibility in the person's speech and in the way they think and their actions. There is indiscretion. That means that they are much more willing to do things that they usually won't. Like there is no more filter whenever they talk back to authority figures, or they are willing to do much riskier things for like a thrill, such as racing, cheating, doing things that are very high octane, high adrenaline. Grandiosity, so they're very confident in doing these things. These two play very well together just because the grandiosity feeds the indiscretion. Flight of ideas is very similar to distractibility, but instead of just being distracted, they have too many ideas at the same time. So when you interview the patient, they may say they have a lot of ideas for an upcoming book that they want to write. And let's say they've never written a book before, but there's too many things and they have too many ideas, and that's why they're not unable to complete a task. Of course, there's the increased activity. And these people are manic, as the term implies. They are going to want to like power clean the house and do things very, very thoroughly. They won't just vacuum or do the dishes. They'll scrub at the strainer in the sink, or they'll go clean through all the drawers, and they will do everything times 100, right? Of course, there's a sleep deficit. Usually, if you ask their partners or their family members, people will say that they only sleep about 3-4 hours a day, and they can go like for hours and hours with a lot of energy. There's no crash. And also, they are going to have very pressured speech. It's very distinct. They're forcing every word out. They're speaking very, very fast, and a lot of the times, their words run together along with the flight of ideas and the distractibility. When these people are speaking, you feel like you're kind of caught in a roller coaster. Everything's going every which way. So, to describe a manic episode clinically, this has to happen in at least a week. So, they can be elevated, but they also can be very irritable just because they have a lot of ideas and a lot of like indiscretion, an elevated mood, increased energy. It doesn't necessarily mean they're happy. So mania is pretty serious. It's not just like you're elevated. This requires hospitalization because the indiscretion can be very, very dangerous to them and the people around them. So the criteria has to be at least 3 of the mnemonic. Hypomania is the elevated mood, the increased energy, but it's much less severe. So it requires no hospitalization. Okay, so bipolar 1, bipolar 2, this is a very important thing to distinguish. Bipolar 1 is worse. Bipolar 2, not so bad. Like bipolar 2, you don't have to be hospitalized. Bipolar 1, there has to be a manic episode, which requires hospitalization. A major depressive or a hypomanic episode usually follows, but it's not always there. So it's one hospitalization. And then it's different from like a psychotic episode because this recurs. So there's a history of it. Bipolar 2, there has to be at least one hypomanic episode, and that's always followed by a major depressive episode. And it's not just them feeling a little bit sad. It's like it meets every criteria for major depressive disorder. So remember, it's the MSIG-E caps. And between the two of them, bipolar 2, usually the mood is euthymic, which means normal, between the episodes of hypomania and depression. One really important thing to keep in mind is the higher the high, the lower the lows. So though these people may not meet manic criteria, the hypomania can have, peaks and troughs. So the higher the peak, the higher their mood is elevated, the depression is going to hit a lot harder. Antidepressants are contraindicated in bipolar because they can destabilize the mood. So bipolar is very, very high with the suicide risk. So we don't give antidepressant. Instead, we give the mood stabilizers and the atypical antipsychotics. If one antipsychotic does not work, we switch it to the other, but we remain in the same class. That's really important. Cyclothymic is just a milder form of bipolar, and it's kind of like bipolar 2, but the depression isn't that bad, and the hypomania isn't that bad either. So all of this lasts at least 2 years with the symptoms present for at least half of the time, and there is going to be the euthymic episodes that last at least 2 months. That's a bit of these are just like, details. What's more important to remember is they last more than 2 years. Okay, so major depressive disorder has the recurring symptom episodes that last at least 2 weeks with 5 of the SIG-E caps. So, it should be M SIG-E caps. So the M would be mood. Mood is, of course, depression. And they have to be depressed like every single day at all the time. There is no remission of the symptoms. They are constantly depressed for at least 2 weeks. The sleep disturbances, it usually presents with hypersomnia, but it could also be insomnia. It depends, but it's, of course, very different from normal sleep. Interest is going to decrease, which is anhedonia, so they are not going to be happy with any kind of activity that usually brings them joy. So maybe they really liked playing bingo, and all of a sudden or not really suddenly, but like the interest and the pleasure coming from playing bingo has decreased until they are only left with sadness. They're usually filled with feelings of guilt or worthlessness. Energy, of course, is fatigued or a decrease, so they always complain about being fatigued, or the limbs feel heavy and they want to go to sleep all the time. Concentration problems are inherent to this disease. They're very preoccupied with feeling very depressed, but their energy levels are also very low, so they usually describe it as being in a fog. Appetite can either increase or decrease, so you gotta watch out for the weight changes. Psychomotor agitation, so they can either be almost, overly energetic. That's not really common. That's usually atypical depression, but usually it's the slowing of movements. They realize that their reflexes are very fast, and when you speak to them, it takes a long time for them to gather their thoughts and speak the words. So that's the psychomotor retardation. And of course, suicidal ideation. So they say that to clinically diagnose major depressive disorder, it has to have at least 5 symptoms. However, the one exception is the minute they have a suicidal attempt, that's instantly diagnosed as major depressive disorder. It doesn't necessarily have to have all 5, or it doesn't always have to include suicidal ideation, but the minute they report that they've been thinking about suicide, or they've at least tried suicide, that is a instant diagnosis of major depressive disorder. So how do we treat it? CBT and SSRIs together. So those SNRIs are going to be your second line treatment, and in the worst case scenario, you give ECT. So the major depressive disorder with psychotic features, so that would be the agitation, mood would be irritable, but they would also have hallucinations or delusions. So the psychotic features are usually congruent with the mood, so they have depressive themes, and they're only in the context of the major depressive episode, which is different from the schizoaffective disorder. So in this scenario, when they are sad, they don't hear voices or they hear voices. When they're not sad, they don't hear the voices. In schizoaffective disorder, when they're no longer sad, they still hear voices. So, I mean, that's a very, very, very bare bones explanation of the two of them, but hopefully that's enough to keep them apart and distinct in your mind. What's better? Remember, mood disorders are always better than psychotic disorders. They have a better prognosis. So how do we treat it? We give them the antidepressants with atypical antipsychotics, and in worst case scenario, you give ECT. So in persistent depressive disorder, or it used to be called dysthymia, so it depends on which question you get. You can get either or these terms, but they are the same. These are at least 2 depressive symptoms from the psych ECAPs that last at least 2 years in adults and 1 year in children. Seasonal affective disorder, it's pretty self-explanatory. It has to occur for at least 2 consecutive years. Those you treat with antidepressants and phototherapy, of course. This is like the only disorder that you can prescribe a vacation for. Depression with atypical features, this would be mood reactivity, hypersomnia, hyperphagia. This is eating too much, and leaden paralysis. And of course, with that, you treat with CBT and SSRI. And then MAL inhibitors would be the second line. Peripartum mood disorders, so they are going to be they used to be called postpartum depression or psychosis, whatever, but now they call them peripartum. But once again, they're the same terms. Keep that in mind, because nowadays with all the tests, they're always trying to change up the language. But more importantly, the onset occurs during the pregnancy or within 4 weeks of delivery. So if the patient already had a mood disorder, so like major depressive disorder, this of course will worsen, because remember, in pregnancy, any underlying condition will come to the forefront. So mood disorders along with like physical disorders. So if somebody's like genetically predispositioned to diabetes, or they're like pre-diabetic, after their pregnancy, after they give birth, they will be full diabetic. So the postpartum blues are the tearful, fatigue, and depressed affect, but it resolves within at least 2 weeks. So the treatment is supportive. You want to recommend them to some kind of like group therapy, a mommy group, things like that. And with major depressive disorder with peripartum onset, formerly called postpartum depression, these meet all the major depressive disorder criteria. So you want to treat this with medication along with CBT. So what's the difference between the blues and postpartum depression? So with the postpartum blues, the mom can enjoy the baby. So they know they are sad, but when they look at the baby, they still feel like, oh, this is my child. I'm so grateful they are in the world. I love my child, even though there's some kind of like weird feelings of guilt and like sadness and just the blues. It's a weird mix, but they still can enjoy the child. With postpartum depression, unfortunately, they look at the child and it's almost like a unreality. They don't really register feelings of joy or contentment or anything with the child. The child is just there and they are just sad. Postpartum psychosis is, of course, the most dangerous one, because it is going to present as hallucinations and delusions. So the mood congruent delusions is important, because if they are depressed, they're going to have the delusions of, people, or like of them being like very sick, or God telling them to return along with the child, or like save themselves, things like that. If they are manic, then they can have delusions of persecution, and they may think that like, hey, if they remove themselves and the child from the equation, then it might be best for everybody involved. So, of course, those are going to be thoughts revolving around harming the baby or the self. So this is particularly dangerous, so you really want to pay attention to whether this is the woman's first pregnancy, family history, their medical history of any kind of mood disorders, medication change, and whether they have a very good support system or not. So with this one, instantly you treat with hospitalization. So this is whether it be voluntary or involuntary, because this is dangerous to the child. And then you give antipsychotic and electroconvulsive therapy. So the suicide risk is SAD persons. So it's more common in female, but males are more likely to complete it. And the age is definitely going to be on the ends of the spectrum. So it's either like teenagers or the very elderly. Depression, of course. Previous attempt is the most important one, the most important aspect that test takers or test makers love to test people on, because they'll give you like, oh, of all these risks, which one is the most likely, like what in their history is most likely to point them into, point you in the direction that the patient might commit another suicide attempt. It's always previous attempt. So the risk would be, usage of any substances, psychosis, sickness, and that doesn't necessarily mean mood disorders. This also means like terminal illnesses. So patients with like long-standing terminal cancers, of course, that increases the risk. Another really important one is an organized plan. That's why whenever you ask a patient, like, hey, have you ever thought about hurting yourself? And they say yes, always follow it up with, have you ever had a plan to do so? Risk would be zero, spouse support or like a social circle. And then the stated future intent is really important too, because they say like, hey, I might try again. Then you want to commit them to a psychiatric inpatient unit. So what will reduce the suicide risk the most? In medication, that would be lithium. But the one treatment that reduces it the most out of all of the medications and treatments and like psychotherapy, that would be ECT. That's why ECT is like the last resort. So ECT, you give it for 3 reasons. If the patient is not eating, if the patient is catatonic, and if the patient is actively trying to commit suicide. So remember those 3. Okay, so that's it for now. Next time we'll cover the anxiety disorder. Study hard. Good luck.